All right, welcome. Today we're looking at carpal tunnel syndrome. You know that very common thing, patient comes in, tingling hands.
Yep, happens all the time.
And we all have our bedside tests, but are we really thinking about how well they work? Especially when, you need a fast, accurate diagnosis.
Absolutely. Getting it right quickly makes a huge difference for managing carpal tunnel syndrome.
So today we're focusing on that smart use of bedside tests for better patient care, getting that diagnosis faster, more confidently.
Exactly. And just to recap, carpal tunnel syndrome is, it's an entrapment neuropathy. That median nerve gets squeezed in the wrist, in the carpal tunnel.
Right. The compression causes the symptom.
Precisely. Often from inflammation, repetitive movements, things like that. So our tests, they basically stress that nerve a little to see if we reproduce the symptoms. We'll look at three main ones.
Okay, let's start with a real classic. Phalen's test. Can you just walk us through how you actually do that one correctly?
Sure. So for Phalen, you ask the patient to put the backs of their hands together, the dorsal surfaces.
Right, pushing the wrists down into flexion.
Exactly, maximum flexion. Almost like a reverse prayer position. The key is they need to hold this for about 30 to 60 seconds.
60 seconds can feel like a long time in that position.
It can, yeah. But that sustained pressure is what we need to potentially bring out the symptoms. If they stop early, you should note that time.
Okay, so they're holding that position. What exactly makes it a positive test? Is it just any discomfort?
No, it's quite specific. A positive Failins is when you reproduce that tingling, numbness, or sometimes pain. But crucially,
So it has to be in the right place.
yes, specifically in the median nerve distribution. So thumb, index finger, middle finger, maybe the radial side of the ring finger too.
But not the pinky.
Definitely not the pinky or the ulnar side of the ring finger. That points elsewhere, maybe ulnar nerve issues. That pattern is super important for differentiating.
Got it. That's a key distinction. So how good is Phalen's, diagnostically speaking? Can we hang our hat on it alone?
Well, it's widely used, but no, not really as a standalone. Its sensitivity is maybe 65 to 85%.
Okay, so it picks up a fair number of cases.
Right, but the specificity is around 75 to 87%. That means it's not perfect at ruling the condition in. You might get some false positives.
I see. So good for screening, maybe flags the possibility.
Exactly. But relying only on Phalen, you could miss some early cases or maybe investigate someone who doesn't actually have it. It's just one piece.
That makes sense. So if Phalen's gives us one clue, what about the other big one? Tinel's sign. How's that one performed?
Tenel's is different. You're directly provoking the nerve. So you tap lightly over the median nerve right at the volar wrist, the palm side, over the carpal tunnel area.
Just tapping with your finger.
You can, but tapping should go on for maybe up to 60 seconds. And actually a little tip. Using a reflex hammer sometimes gives a more consistent tap.
Ah, okay. More controlled stimulus.
Yeah, I find it can sometimes bring out a subtle response that fingers might miss, especially if the patient isn't quite sure what they're feeling.
And what are we looking for with Tinel's? What's a positive sign feel like?
It's usually described as tingling or sometimes like little electric shocks, zappy sensations.
Okay. And again, location matters.
Absolutely. Those sensations should radiate along that same median nerve distribution, thumb, index, middle fingers. It's a provoked feeling from the tapping, not from holding a position.
Right. Different mechanism. So how does Tinel's stack up against Phalen's in terms of accuracy?
Tinel's sensitivity is a bit more variable, ranges maybe from 50% up to about 82%.
50%. So potentially missing half the cases.
It could, yeah. That's its main limitation. Generally less sensitive than Phalen's, but its specificity is pretty decent, around 77 to 89%.
So if it is positive, it's more likely to be real.
Exactly. It's relatively specific. Good for helping confirm the condition if positive, but a negative, Tinel's doesn't really rule it out effectively.
Okay, so Phalen's may be better at catching it, Tinel's may be better at confirming it, but neither is perfect.
Precisely. Both have limitations. Relying only on those two, you're likely to miss some, especially those early or subtle presentations.
Which brings us to the third test, I assume, the hand elevation test. This one might be less familiar to some folks. How does it work?
Yeah, it's gaining traction for good reason. It's super simple. You just ask the patient to actively lift both hands up above their head.
Just hold them up?
Yep. Elbows and shoulders relaxed, not locked out, just comfortably flexed. And they hold that position for up to 2 minutes.
2 minutes and no equipment needed?
None at all. That's the beauty of it. perfect for any setting.
Okay, incredibly simple. What counts as a positive result here, and why does just raising the hands do anything?
Positive is if they develop those paresthesias, tingling, numbness, maybe pain again, in the median nerve distribution within those 2 minutes. Just a different way of stressing it compared to Phalen or Tinels.
That makes a lot of sense physiologically. Okay, so the big question. How accurate is this test? Does it really outperform the others?
This is where it gets interesting. The hand elevation test has really high specificity. We're talking about 98%.
98, wow. So very few false positives.
Extremely few. If this test is positive, you can be very confident the patient likely has carpal tunnel syndrome. It's excellent for ruling in the condition.
And sensitivity. Does it catch cases well?
Sensitivity is also quite good, generally around 75 to 87%. So comparable to or even better than Failins in some studies. Overall, research shows it often has better diagnostic accuracy than the traditional tests.
So higher specificity and good sensitivity. Seems like a powerful tool.
It really is. Simple, yet very informative.
Okay, let's put this all together then. We've got these 3 tests. How do you actually use them effectively in a clinic, like in a real patient scenario? Combining them seems key.
Absolutely. Combination is the way to go. Let's take an example. Say a 52-year-old guy, maybe works construction, comes in, says his hands have been tingling and numb at night for 3 months, wakes him up.
Okay, pretty classic story.
Right. And he mentions maybe some mild numbness in his thumb, index, middle finger during the day too.
So you start your exam.
Yeah. You do Phalen. He holds it for, say, 45 seconds and says, yeah, maybe a little tingling. I'm not sure if that's it, though. Kind of mild, equivocal.
Okay. Then Tinels.
You tap over the nerve. He reports maybe a brief little tingle just into his index finger. Again, kind of weak, maybe positive, maybe not.
So you're left feeling uncertain, that diagnostic gray area.
Exactly that, maybe feeling.
Yeah.
Phalen and Tinels are useful, but with their moderate sensitivity, they can be ambiguous, especially early on.
And this is where the hand elevation test fits in.
This is perfect for it. You ask, okay, now just raise your hands above your head. He does. And within, say, 60 seconds, he goes, whoa, yeah, that's it. That's the numbness, the tingling. Just like at night, it's in my thumb and first 2 fingers.
A much clearer response.
Much clearer. That definite reproduction of his specific symptoms combined with the test's high specificity really boosts your diagnostic confidence. It helps confirm things.
So it acts like a tiebreaker almost, or a strong confirmer.
Yeah, a very strong confirmer in this case. Simple, no equipment, and really helps solidify that suspicion of median nerve entrapment at the wrist.
What about trickier cases? Maybe someone with diabetes or who's pregnant. Their symptoms can be a bit different sometimes.
That's a great point. In those cases where baseline nerve health might be off or symptoms are more diffuse, individual tests like Phalen or Tinels might be even less reliable, maybe mildly positive just due to general nerve sensitivity. But again, that high specificity of the hand elevation test is so helpful. If that test is clearly positive, reproducing symptoms specifically in the median nerve distribution, it strongly points towards carpal tunnel syndrome, even among other confusing symptoms. It helps you focus your management.
So it helps cut through the noise in complex presentations, too, differentiating it from, say, a neck problem radiating down.
Precisely. While you always need the full history and other exam parts, the pattern across these 3 tests really helps localize the issue. A positive hand elevation test is particularly strong evidence against something like cervical radiculopathy being the sole cause of those specific hand symptoms. You build a stronger case right there at the bedside.
This is really practical stuff. So boiling it all down, what's the main takeaway for clinicians listening?
I think the key message is, don't just rely on one test for suspected carpal tunnel. Combine them. Use Phalen, use Tinels, but definitely add the hand elevation test to your routine.
Because that combination boosts accuracy.
Dramatically. Especially for those subtle or early cases. The hand elevation test, with its simplicity and that really high specificity, is just invaluable. It lets you be much more confident in your diagnosis.
And that leads to better, faster management for the patient.
Absolutely. You can identify it confidently and get them started on the right path, whether it's splinting, therapy, or other interventions.